Thank you everyone for coming out to Carolina Health Samaritan Society's 7th virtual shadowing event. We are very happy to welcome UNC dermatologist and clinical professor Dr. Morrell as our physician presenter for today's virtual shadowing event. Dr. Morrell attended medical school at UNC School of Medicine. He then went on to complete his dermatology residency at the UNC School of Medicine and his pediatric dermatology residency at the Children's Hospital of Wisconsin in Milwaukee, Wisconsin. Dr. Morrell's specialty interests include atopic dermatitis, acne, genodermatoses, and systemic therapy for complex medical issues. Dr. Morrell currently serves as a vice chair for education at the UNC School of Medicine, as well as the director of dermatology residency training program at UNC. Dr. Morrell, we are all very excited to learn more about dermatology as well as your own personal career journey. You're welcome to start whenever.
Thanks, Margaret. Thanks for that great introduction. Hello, everybody. It's a pleasure to be here today. I am, like Margaret was saying, I'm a pediatric dermatologist here at UNC. I'm also our residency program director, so I have a chance to meet with a lot of aspiring physicians and medical students aspiring to do dermatology or other things. You know, here at UNC, we want you guys to find your passion, whether that's in medicine or otherwise. So, you know, it's all about the journey. When I was in your shoes, I thought I wanted to be involved with healthcare, but wasn't sure what. So then I did graduate school in physical therapy and worked in physical therapy for 4 years, and then decided to go to medical school. So, you know, my path was not as direct as others, but again, it's all about your journey and what you experience, what you learn along the way. I'm going to share with you some common things that we see in our clinic in pediatric dermatology, and hopefully to stimulate you to think about that as a potential career. We'll get through it, and then we can open up for questions along the way. I'm very lucky. There's three faculty members that do pediatric dermatology, and so I'm very fortunate to work with wonderful co-faculty members with Dr. Neiman and Dr. McShane. Most of our clinics are here at our Southern Village location. We're on the top floor above the Town Hall Grill in Rasa, Malaysia. If you know that area there, this is our core UNC dermatology facility. Like I said, three of us do pediatric dermatology, and there's about 20 faculty members that do adult dermatology. We also provide services to a clinic in Arlington, at the UNC Hillsborough Hospital, and then we have a clinic in Raleigh, close to Rex Hospital there. You know, what's great about working at UNC is that we see people regardless of their ability to pay or their whether they have insurance or not. And it's nice to be a faculty member at UNC to take care of people of North Carolina, and not have to worry about what their resources or lack thereof. So it's been very, very rewarding and great place to be. So if I were to give you what a pathway to pediatric dermatology is, and there's a pathway to medicine as well, is that you guys are, you want to be excellent in everything that you do during your undergrad. Don't let anybody tell you have to do a certain major. You can be any major. Probably, back when I was in medical school, everybody was either biology or chemistry. And in medical schools like to have a lot of diversity of educational backgrounds. Obviously, you have to do your prerequisites, but you don't have to be a science major. And you want to pursue your passions, both in and out of the classroom. So you want to have things, or what I call stuff, on your CV for your application, but you don't have to do everything. Whatever you just choose to do it because you feel passionately about it and you put a lot of energy, and you're kind of an expert in that area. Don't spread yourself so thin that you don't do anything well. Okay. So medical school is 4 years. Again, that's for going into dermatology or in other competitive specialties. You want to learn as much as you can for your future patients, perform well on your board exams, and during your third year of medical school are your, what we call their clerkships. They're your rotations, and your 6 core rotations are going to be internal medicine, pediatrics, family medicine, OB/GYN, psychiatry, and surgery. And so you just want to perform well with those patients and on that team. And so, because you get grades on that and you get your letters, recommendations from those experiences. And we just had the match in, so then during your 4th year of medical school, you have your match where you match into your residency. And we just had the match about a month ago. And nationally for dermatology, well, at our program, we had 700 applications for our 5 spots. And so nationally, there's about a little over 300 spots for dermatology. So you can see that it can be competitive there. For dermatology training, you have to do a year of an internship that's not in dermatology first. I did mine in pediatrics. As Margaret said, some people do internal medicine, or you can do this, what's called a transitional year, which you're basically is like a 5th year medical school, and you're an intern on those 6 core rotations we talked about with the clerkships. For dermatology, it doesn't matter what you do. You just have to have a 1-year internship prior to starting dermatology. And the dermatology residency is 3 years. And then during those 3 years, that's when you're going to decide what part of dermatology. Are you going to be a general dermatologist and see people from all ages, from birth to geriatric years? Are you going to be a procedural dermatologist and do mostly surgeries? Are you going to be a dermatopathologist and spend a lot of time looking at slides under the microscope from skin biopsies? Or are you going to be a pediatric dermatologist? Majority of people become general dermatologists, but it's a chance during those 3 years for you to define what those passions are. And if you're going to be a pediatric dermatologist, a dermatopathologist, or a procedural surgical dermatologist, those fellowship years are just 1 year in duration. So when you finish your 3 years of dermatology, you sit for your boards to be certified as a dermatologist. And then if you do a fellowship, then that's another certification test, board exam that you have to do as well. And so that's, if people want to know how to get to pediatric dermatology, that's how you do it. Okay, any questions about that, about those steps along the way? Do whatever you feel passionate about and do it well, right? Some other your friends are not going to understand what the pre-medical journey is like, and sometimes you just have to educate them and say, that's all right, you guys go ahead and do your thing. I'm going to lock in and do this now, but I'm going to catch up with you later. And so wellness is really important, right? So you need sleep, exercise, and have a good time. Okay. All right, I'm going to share with you briefly my top 10 pediatric dermatology conditions that we see here at UNC Dermatology. We'll go through them. I'll show you some kind of fun pictures about that. I'm going to divide it into inflammatory conditions, infectious conditions, autoimmune conditions, and just like bumps or lesions. So probably the top 2 things that we see in pediatric dermatology are atopic dermatitis and acne. Right? Atopic dermatitis, very common. It's when people say they have eczema, the medical term for that is atopic dermatitis. And so people with eczema have a lot of erythema or redness. They have a lot of scaling, right? All the scale. They have a lot of itching. When you do a lot of itching, you get increased skin lines. This is over his ankle. It's called lichenification. And this can be very uncomfortable. You have open areas of your skin. You're more likely to have secondary infections. The itch is very intense. It keeps you awake at night. It affects your sleep, affects your parents' sleep, affects your ability to perform well in school. It runs in families and in patients that have asthma, allergic rhinitis, or hay fever, and eczema. It's an overactive immune system. Hyperactive immune system, either in your skin, your nasal passages, or in your lungs. There's not a cure for eczema or atopic dermatitis, but we can control it. And we're getting more and more people with it. It's 10 to 20% of the population. 60% of people will have it onset within the first year of life if they're going to have it. 80% within the first 5 years of life. So there are some people, but it's uncommon, that will have an onset of eczema after 5 years of age. So it can happen, but if it does happen in medicine, we have to consider, is there something else that's going on? Like, do they have an infection, a systemic infection, or are they on a medication that's causing it? Or if it's really just they're allergic contact dermatitis with it. All right, so this is atopic dermatitis or eczema. In the first year of life, it's very intense on the face, as you can see when I first met him on the left, but then I give him a good topical medicine and we can make it go away. It's going to come back and it's going to be like a roller coaster ride through time, but I'm going to provide the family with something they can turn it off very quickly. And so then the kid can sleep, the parents can sleep, everybody's happy. And then we just keep it under control until they age out of it. Here's another little fellow with a bunch of eczema, pretty severe all over. And so I give some treatments, and that's him a couple of weeks later, right? So again, we haven't cured it, we're controlling it. So that was atopic dermatitis or eczema. This, you guys know, this is another very common diagnosis, right? This is acne. And in medicine, we call it acne vulgaris, and vulgaris just means common. So common acne. Acne happens to almost all of us at some point in our time. It is starting younger in our females. My daughter started when she was about 8. It's because different things are going on. Hormonal changes are happening earlier, and then that's when our sebaceous glands, which are on our face, our chest, and our back, tend to have more sebum that are in their follicles, and that can plug up the follicles and cause blackheads and whiteheads. And then if the immune system doesn't like those, then you get those big inflammatory, cystic nodules with it. Acne can have a profound impact upon your psychosocial well-being, employment. It can cause scarring, and as you know, probably know, it has a huge impact on your wallet. There's so many products that are available out there that are marketed towards people with acne. When I see patients with acne, as I walk into the room, I immediately classify them into 2 categories. They're either superficial or comedonal. Your blackheads and whiteheads are called comedones, or the patient has inflammatory acne. I have 2 kids. My son only had the superficial acne, whereas my daughter had the more deeper inflammatory acne. And that's just the difference in how their immune system reacted to those little plugs, the blackheads and the whiteheads on their skin. If you only have the superficial comedonal acne, really the only treatment you need, and the best treatment for it, are your topical retinoids. And so the brand names, that's going to be Differin and Retin-A. Generic names, those are Adapalene and Tretinoin. And those are going to be your most effective. When the kids are younger, you can try the salicylic acid washes and the benzoyl peroxide washes, and they're okay. They'll help milder, but if they're not working, you need to start using the topical retinoid. And so there's this therapeutic ladder of retinoids that are available. And fortunately, Differin, the 0.1% gel now, is over the counter. It's the only over-the-counter acne retinoid that's available. So if somebody only has little, superficial acne, then that's a great place to start. And you use it at nighttime. It helps. People might flare initially, but after about a month of use, their acne lesions will start going away. Okay. If that doesn't work and they're tolerating, then you can work up your ladder and get something stronger and stronger. However, as you go stronger, you get better results with the acne, but you can cause some dryness and skin irritation. So you have to get the right one where the people can control it, can maintain it on a regular basis. Unfortunately, we don't have a treatment that just spot treats acne. Our acne treatments do better the more consistent you are with. If the patients, when their kids are younger, they only have the superficial acne. If they move on to deeper acne as they get older, then we're gonna go on to oral treatments. We're gonna keep our topical retinoid going, but we're gonna move on to oral, and that's either gonna be our oral antibiotics, and that's the best ones are gonna be doxycycline and minocycline. If that doesn't work, or if they can't tolerate it, or if they want to avoid oral antibiotics for a period of time, then the best and the next choice is called isotretinoin. In the old days, this was the brand name of Accutane. And isotretinoin is the only treatment we have for acne that has a chance to cure your acne. That 75% of people who take isotretinoin are cured of their acne and don't have acne again the rest of their lives. That means 25% do, but that 25% of people, it's usually a lot less severe, and then you can just use your topical over-the-counter Differin gel to control it from there. Okay. Unfortunately, isotretinoin and Accutane has a lot of bad press on social media. It's a fantastic medication and done in appropriately with regular lab testing and things like that. The majority of people do fantastic with it and are so glad that they did it. The course of isotretinoin the course is about 6 or 7 months. We do blood work about 3 times just to make sure that the patients their liver and their blood counts are doing fine. For our female patients, the only side effect that we worry about is that it's a powerful teratogen, meaning it can affect a fetus if there's a pregnancy while you're on it. So for our female patients, we're required to prove that they're not pregnant each month, even if they're not sexually active. But if females take it, and don't get pregnant during that time, which is the vast majority, it has no impact on any future pregnancies that our female patient might have later on in life. And in fact, you only have to wait 1 menstrual cycle after you stop the medication before you can safely conceive and not have it affect your fetus. And again, if you have really bad nodular cystic and scarring acne, then we just go straight to isotretinoin, just to go ahead and stop future scarring with it. So let me show off some patients we've seen with really bad acne that we treated with isotretinoin, and you can see, none of our other medications would have helped this guy with it. So here he is at the end of the course. Everybody complains with Accutane or isotretinoin of dry lips. All right, and that happens to everybody. But just regular chapstick, any of your favorite lip lubricants will help to control that. Here's a patient I showed you at the beginning with bad nodular cystic, and now here she is at the end of her course. This kid had just mostly superficial acne, but despite all my treatments with the topical retinoid, I couldn't get her better. So then we just did oral isotretinoin. It works for everybody. Similar story here. Okay, so isotretinoin is a fantastic medicine. I think of most females go to age 18 with acne, and most guys to age 20. There are certainly there's probably 10 to 20% of people that will go into their adulthood with acne. And so if I see patients in their young adulthood with continuing acne, that can go on until it'll slow down, but it can go into your early 40s before you fully goes away. Then in my opinion, those patients, the 20-year-olds with continued acne are candidates for isotretinoin. And instead of messing around with other treatments, antibiotics that you might have to be on for years and years at a time, I think it's wise and safer to go ahead and do 6 or 7 months of isotretinoin, and then hopefully you're done with it the rest of your life. All right, that was our most common acne and atopic dermatitis. Psoriasis is really common in dermatology clinics. In psoriasis, you get these well-demarcated erythematous plaques. Plaques mean you can feel it, with overlying silvery scale. Okay, so if you hear about that, red plaques with silvery scale, everybody's talking about psoriasis. And it typically is over your extensor joints, so your elbows and your knees, and it's very common on your scalp as well. Okay. There is a form of psoriasis called Guttate Psoriasis, and Guttate means like little raindrops, okay? And so we see Guttate Psoriasis more in kids than we do in adults. And typically Guttate Psoriasis is after a kid has strep throat, streptococcal infection, and that initiates the immune system to start psoriasis. So if I see a patient with a new onset of Guttate Psoriasis, most of the time when I ask the family, tell me about the strep throat, they look at me like I'm a seer. They're like, how did you know? It's a very common story with that. Again, well-demarcated plaques with silvery scale. You think about psoriasis, so you look for other clues. And so on this young man, he's got them on his elbow too. So that confirms your diagnosis, psoriasis. The course of psoriasis is unpredictable. It typically starts in your elbows and or your scalp. It will get worse with infections, stressful times. It gets better almost universally in the summertime because of increased ultraviolet light. For kids that have psoriasis, there's a chance that they'll outgrow it. It'll just kind of go away. There's also probably equal chance that it will continue on through life or get worse with it. So in patients with psoriasis, as they get older, you need to ask about their joints, because psoriasis, I don't know, 10 to 20% of patients can cause arthritis as well. All right, here's another inflammatory condition of the skin. It's very itchy. And this patient, when we see it around the belly button and below, that's a very common story. It's an allergic contact dermatitis to nickel. And supposedly 25% of the population is allergic to nickel. My son was. So yeah, that's 1 out of 4 at my house. So the number holds true. People with eczema are more likely to get sensitized to nickel. The best time, a time to get sensitized, right, is when you're an infant. You get your ears pierced if you use some costume jewelry. Costume jewelry always has some nickel in it. Nickel's an alloy metal that provides a lot of strength to our metals, but it's cheap. But a good percent of people do develop allergies to it. My son had it. I could tell he had it. He was allergic because on his onesie with the little snaps, everywhere the little snaps touched his skin as an infant, he get a little round circle of allergic contact dermatitis. What's kind of neat, we have this test in clinic called the dimethyl test that we can put on a Q-tip and rub it on metal products and be able to tell if the patient's allergic to nickel. We can test the products and tell them which ones have enough nickel in them to cause the allergy. So here's a kid I saw years ago that she came in for the rash on her cheek, right? And then we kind of looked at the rest of her, and you can tell she had her ears pierced, but wasn't wearing earrings because she breaks out. She had this on one cheek, and then she had this on her tummy that she was covering up with a Band-Aid. And how many of you guys had one of these belts? These were so popular, like, and they came in all different colors, right? Almost all females, teenagers had these, right? These belts are notorious. They have tons of nickel in them. Okay, and so I don't know. They don't seem to be. I don't see them as much as I used to. So we're seeing less of nickel dermatitis. But anyway, she was using an old flip phone, a hand-me-down flip phone from her parent. And here we did the dimethylglycine test, right? And we rub it on the frame here, and just because it's old and it's got nickel in it, and that's what she was allergic to on her cheek with her flip phone. So that's allergic contact dermatitis to nickel. All right, let's move into some skin infections. Right, these are some pretty gnarly looking. We would describe this as verrucous lesions. And these are warts. Right? Now, this patient he was immunocompromised. He'd had a renal transplant, so his immune system, all his medications so that he didn't reject his transplanted kidneys, it affected his ability to fight off the wart virus. Right? And so warts, the medical name for warts are verrucae. And so they come in lots of different places, but they're all kind of rough. And all of our treatments for warts are about 75% successful. I had warts as a kid. Both of my kids had warts. That during our childhood years, our immune system doesn't see the wart virus, which is HPV, human papillomavirus, very well. But eventually it will. So you don't have to treat warts; they'll eventually go away. But if it's starting to bother the kid, getting in their way or affecting what they do or wear, then we do treatments to try to get the immune system there to see the virus. And then once the immune system eradicates it, then we're good. The HPV vaccine, Gardasil, and the others address the specific HPV subtypes that can cause cervical cancer. And there are reports of kids having common warts elsewhere on their body, getting the Gardasil vaccine and having their warts go away. But unfortunately, it only is pretty much specific to the subtypes, and there's over 100 different types of HPV. Hopefully, as our vaccine technology and our knowledge about HPV subtypes, maybe someday I'll be out of the wart business. But right now, we still have plenty. So these are just different treatments that we can do to try to stimulate the immune system to see the HPV. And usually after a visit or 2 or 3, we're able to get the immune system there to fight off and identify that virus. Right? That's what I tried lots of different treatments for this kid. Even though he had a compromised immune system, I did the contact acid sensitization, so I introduced a chemical to his skin, through his skin to his immune system. He built up antibodies and an allergic reaction to it that then I applied to his warts, and even the little amount of his immune system was able to get rid of those pretty significant warts. I think of these as cousins to warts. These are called molluscum. It's another common skin virus in kids and young adults. My son had it. And unlike warts, the warts I showed you that are verrucous, right, are jagged tops. These are smooth and domed, all right? So these are shiny dome-shaped papules. They can have a little plug in the middle. That's where the wart core virus is. And these are called molluscum. The same story for warts is for molluscum, that eventually all molluscum lesions will go away because the immune system will identify it. Where it can take the immune system up to 10 years to see. The wart virus, usually within 2 to 4 years, the immune system will get rid of your molluscum lesions. And there's different treatments that we can do in the clinic to help to speed up that if patients want. All right, so that's molluscum contagiosum. When your molluscum lesions turn red and inflamed and almost look like little pustules, that's a good sign. That's this patient's immune system that's fighting, it's identifying the virus and fighting it and chopping up. And then I would expect in a month or so, they're all going to go away. And once our immune system sees the wart virus and once it sees the molluscum virus, then you don't get reinfection with those skin viruses again, even though those viruses are still on you. All right, so those are skin infections. How about some autoimmune conditions? Alopecia areata. So, there's lots of different causes of alopecia. I've got what's called male pattern or androgenetic alopecia. That's genetics and, testosterone kind of disposition. This is a young kid that has these round circles, and that's his immune system that's fighting it. And that's called alopecia areata. Autoimmune, it tends to run in families. If you lose all of your hair on your scalp, that's called alopecia totalis. And then some people rarely will lose all the hair on their bodies, including their eyebrows, their eyelashes, their nose hair, their axillary hair, their pubic hair, their arm and leg hair. That's a very strong autoimmune condition that's fighting off those hair follicles. Now, if the immune system decides to stop attacking the hair follicles, then these patients' hairs will come back. I'm a lost cause. Mine is not autoimmune, mine is genetic. So the treatments that help our patients with it, they're not going to do much for me. So here's a patient of mine that I had with alopecia totalis, and I injected steroids. I started with one little spot here, and you can see I told with the steroids it made the immune system go away, and she starts to grow hair. And then through time, we just kind of keep going with it, and we got a pretty good coverage, and she was pretty happy with it. Okay, so we're just kind of telling the immune system to leave those areas alone. And that's very similar to this condition called vitiligo, where people lose their pigmented skin, and Michael Jackson was reported to have vitiligo. And so this is an autoimmune attack of the melanocytes in our skin. And so our melanocytes are very touchy and are fragile, and if anything attacks them, they'll stop making pigment. Vitiligo. Again, 2% of the population. It's well demarcated, depigmented areas. It can be symmetrical. Then we call it vitiligo vulgaris. We can put them in a medical light box that does narrow band, not the broad band that you get from tanning beds, but this is a safe medical grade narrow wave, narrow band for treatment of vitiligo and other conditions. And then with topical treatments, we can get the pigment back as well. And last two diagnoses are going to be what I call lesions. And this is a patient with a birthmark. It's called a congenital melanocytic nevus, and you can get these in different sizes and shapes. They can be anywhere. We categorize them by the size that they are because of the potential increased risk of melanoma. If they're large ones, greater than 20 centimeters, if up to 5% of those people can get a melanoma. The smaller ones, it's probably closer to 0% with it. If it's small, we can kind of watch it. If they're big and you want to try to get rid of it, our friends in plastic surgery can do some surgeries with it, and this is a pretty amazing outcome that with it. But that significantly decreases that kid's chances of having melanoma later on in life. And lastly, vascular lesions in kids called hemangiomas, more common in white female preterm babies. They're there at birth or soon after. They come in either superficial, where they're just on top. They grow for the first year of life, and then they'll go away. Our treatments will try to stop them from growing so they don't leave a mark behind. They can be just deep under the skin as well. And in those patients, they look kind of blue. And so, but there's an oral medicine called propranolol. It's a beta blocker that helps to stop these hemangiomas from growing. And so we can start that to make them go away. And here's a kid that came to me back in January 2010 with it already growing a lot. And then by, in 6 months there with the oral propranolol, it's shrinking down. And so we're going to save it from leaving a mark behind and causing her some issues later on in life. Again, another oral medication that helps to stop these guys from growing. And guys, those are my top 10 of patients that we see. We talked about inflammatory conditions, acne, atopic dermatitis, psoriasis, and contact dermatitis, skin infections, warts, and molluscum, autoimmune conditions with alopecia areata and vitiligo, and then some lesions, common lesions, melanocytic nevi, and hemangiomas. And I'm glad that the UNC Healthcare didn't shut down our presentation, so we made it just in time.
Awesome. Well, thank you so much, Dr. Morrell. We now have time for some questions. If anyone wants to write them in the chat or unmute yourself and ask. I have a question personally. So with the warmer weather and more sun means more people tanning outside. So what do you recommend that we do to stay safe while tanning? I'm sure that tanning is in no way a good thing to do, but what do you recommend?
Yeah, you guys should all go out and make those people put their clothes back on and go inside. So I grew up in, it's a great question and very timely for the time of year, right? The sun, we all love the sun, but it causes photo aging, spots, and skin cancers and wrinkles. Okay. So I was born in upstate New York. My parents grew up in upstate New York. When we were two, when I was two, my dad was transferred to Wendell, North Carolina, and so most of my formative years were here in North Carolina. And my parents, we just didn't know, right? And I have very little pigment in my skin. I don't tan, but I was the kid that mowed everybody's grass in the neighborhood, right? That was my summer jobs type of thing. And I didn't use sun protection. So my parents who grew up in upstate New York, compared to me growing up in North Carolina, I have already passed my parents in the number of skin cancers that we've had. I've had 6 basal cells just from the too much cumulative sun that I received here. Now, my parents have each had 1 or 2 basal cells. So it's just sun exposure, increased sun exposure increases your chance for that. Now, it gives you good vitamin D. So in terms of recommendations, when you're in a sunny area and sunny season, right, is you want to, clothing is going to be your best way to cover up. So you'll see me now walking around the town with a hat on and my sun protective clothing. And there's some really great sun protective clothing. The textile industry, makes some really lightweight, breathable, sun protective, fashionable, colorful products now that compare to what it was, just like 10 years ago. So if you're out between 10 and 4 or 5 in North Carolina in the summertime, I would say have some kind of cover up. And if there are areas that you can't cover up, then sunscreen, SPF of 30 or more. If you're in and out of water a lot, it needs to be the water resistant type. But you guys are in school, you guys should be studying and then staying inside during the middle of the day. So, when we go to the beach, especially when we had young kids, we just go out early. The kids were up early anyway, so we'd be like the only ones out there from like 8 to 10, and we'd be coming in at 10 in the morning. We were worn out and done. Kids would take a nap, we cook, we watch movies, we eat, take naps, and then go back later in the afternoon or go bowling or go watch a movie or something like that. And if you're outside, if you can, seek shade, right? It's amazing with the patients I see, the teenagers I see. I saw a young lady yesterday. She had beautiful skin. She's taken so much good care of her skin in terms of sun protection, and she's a junior in high school. And I told her, when you go off to college, don't ruin it. You're gonna have some of your friends are gonna be out sunbathing. Make sure that you tell them you're gonna be studying or doing something else. You've done such a great job that all your sun exposure you get during your younger years and young adult years they catch up to you.
Thank you for that recommendation. It's really
sure.
helpful.
Thanks for asking.
Mm-hmm.
Any other questions?
How did you decide to get into dermatology?
That's a good question. I did physical therapy first, Cameron. To be honest, I would not have predicted it. You know, I did orthopedics, physical therapy. So if you had asked me when I was going to medical school, I was going to be an orthopedic surgeon. But then during medical school, that's why you do all your rotations. And what I didn't know about orthopedic surgery is that you're in the OR, the operating room, for a long time. And, we've got great orthopedic surgeons here at UNC that, they can do surgeries that are like 4, 6, 8, 12 hours long. I realized quickly as a medical student that I did not have the attention span to be in a room without windows for that long period of time. So I needed to, then I was like, okay, I really didn't know what orthopedic surgery was. I need to come up with something else. And so just during my clinical rotations during my third year, I realized I really liked what I could see, that the skin rashes and lesions, that a lot of times the skin is the window into what's going on internally. So, by developing my visual recognition skills, that I could help out patients that way with it. And so then that's how I did it. But that's what those experience and rotations are all about. There are some of my colleagues in medical school came in knowing exactly what they were going to do, and after 4 years, that's what they did. A lot of people have changed their minds along the way, but that's what I'll start talking to some UNC medical students during their first or second year, and they'll talk about interest in dermatology, and then they'll call me or email me a year later and say, oh, I found my passion, it's going to be medicine and pediatrics or something like that. And as a UNC faculty member, that's what we want. We want our students to find those passions with it.
Thank you.
Sure.
So I always ask, what is your favorite part of your job and your least favorite part of your job?
Favorite part of job. So in academia, I'm very fortunate that and because I get to do some administrative things. Like I said, I was a program director, so half of my time I'm in the clinic, half the time I'm doing academic administrative type of things. So for me, it's a great work-life balance. If private practice dermatologists if they're full-time, they're busy, right? They're doing most of their weekdays they're in clinic seeing patients. So I like with the academic setting because it gives me that flexibility. It probably goes along with that, my short attention span that I was talking about. I love working with patients. I love the interaction with people, hearing their stories about their journeys, how they're dealing with the pandemic, how it's affected their lives, what the kids are doing in school. I love asking the young kids about where their office is in their room, for their setup. And just having an impact, and in dermatology, we can have a really big impact on people's quality of life. So that's a big part of it. Like I said at the beginning, working at UNC, I don't have to worry about people's ability to pay. So that's, a lot of people go into medicine because they don't want to have to deal with the business aspect. My least favorite is just there's the paperwork, the notes that you have to do. There's the electronic medical record is very, there's lots of clicks and typing that you have to do. That back when I was in medical school or as a new faculty member, as a resident, it was all paper charts. And so that was much easier to scribble out a quick note. Overall, we do better medical care with the electronic medical record, but it's the admin aspect of it that goes along with that patient care.
Thank you.
Sure.
Do we have any other questions from any members? I have another one. Is there any particular topical cream or ointment that you find to be particularly harmful and that a bunch of people have been using?
Yeah. So it's, over the last couple of years, the skincare products that have been marketed I think it's one of the fastest growing aspects of our healthcare, our national healthcare. And there's a huge market for it. Whenever the ingredient list is long, even if it's called organic or all natural, there's always a chance that you can have allergies to it. So like I don't know, we see patients that are allergic, they develop an allergy to neomycin or neosporin is a topical antibiotic that's commonly used that you can get. I've seen allergies to that. Burt's Bees products, some people develop an allergy to propolis, which is the pollen part, with it. I think if somebody has open areas of their skin, like with atopic dermatitis, you always want to use more ointments, or that ointments are going to be more the Vaseline based, because our creams have alcohol and other preservatives and chemicals that can be very irritating and burning. Not true allergy, but with it. So, things like that, just not a lot of people, a lot of families, parents feeling like things they think they're safe because they're all natural, but they can have some things in them that can cause problems.